So in terms of Parkinson's, I want to just understand how you approach treating that differently from traditional neurology models.
Well, Parkinson's is an age-related disorder. And I think a lot of doctors, and not just neurologists, but in some countries, primary care doctors manage Parkinson's patients. This applies to Alzheimer's and other neurodegenerative diseases, of which Parkinson's is just one. There are multiple disorders that can look a lot like Parkinson's but aren't. And so I think it's important to see a physician that is experienced at managing Parkinsonian disorders and other forms of dementia to help tease out what are the core drivers of the disability. And is it really just regular Parkinson's, or is it a combination of issues? It could be related to vascular disease in the brain. There are other neurodegenerative pathologies that can mimic Parkinson's disease. And certainly you can have Alzheimer's and Parkinson's at the same time. So I think that as a movement disorder neurologist that focuses on Parkinson's and other similar disorders, we're more likely to tease that out. But even in the literature, experts that see Parkinson's patients, they're still wrong about the diagnosis quite often, but over time, the diagnosis becomes more clear, and we have more tools now than we used to. But ultimately, it's the clinical progression of symptoms and findings that determine what the underlying problems are. And we do that, I think, with a little bit more reliability, and allows us to target and perform earlier treatment with more success.
What are some of the most commonly overlooked early signs of Parkinson's that patients or providers miss?
I think that there are a lot of non-motor features that happen before people start suffering significant disability from Parkinson's. A lot of times it's poor sleep. A lot of times it's acting out your dreams at night. Some of it can be constipation or GI issues, irritable bowel. But the main features that distinguish Parkinson's from other age-related disorders is usually motor findings. So resting tremor is pretty common, but not absolute. And a lot of times people just start getting slower, like they just walk a little slower. And that could go on for years before a provider actually does a full neurological exam where they can tease out that there's some rigidity or stiffness in passive range of motion. And providers, they may miss that if they're not specifically looking for it. And so there are a lot of patients that have Parkinsonism, features of Parkinson's disease, that go undiagnosed for years because they just didn't ever have a thorough neurological examination. Also, sometimes it affects balance and fine motor control. So if you're having more difficulty with writing and fatigability as you're doing things, you get tired, or the leg feels heavy or dragging. That these can be early features of Parkinson's. And sometimes it's cognitive and behavioral, that you're more depressed, loss of interest in elective activities. Sometimes you just become more withdrawn, and it's not depression. It's part of the manifestation of early Parkinson's and other neurodegenerative disease.
Speaking of the non-motor symptoms, how do those, sleep, mood, cognition, whatever it might be, shape your treatment approach?
Well, these aren't necessarily caused by Parkinson's. It could simply be the other way around. Mm-hmm. That as people are aging, changes in the brain are manifesting as a decline in energy metabolism. I call this an energy crisis in the brain. And this can probably go on for years before you actually have a sufficient pathology to be diagnosed with Parkinson's. And so these are all clues of areas that we can actually improve through a more comprehensive metabolic approach to managing patient care.
In what ways do you feel like that differs heavily from other models of treating Parkinson's?
Well, and we had this problem before we moved to a concierge model, where our average visit in the previous years before switching was around 45-minute visits, but they were back to back. So if you had a patient who was complicated, where you're trying to address not only their motor symptoms like tremor or rigidity or slowness of movement, but they also have cognitive decline, or they have depression or anxiety or sleep disturbances that are affecting their overall quality of life. That you felt pressure to just pick one, or maybe just manage their motor symptom. And so I think seeing patients frequently enough with long enough visits to manage those problems is critical. And so we do that now. We were doing it before, but I think now, with the frequency of visits, not just the length of visits, the fact that we are able to see patients every other week, every 3 weeks, with the team, alternating with you, for example. You get a lot more contact with this practice than we could perform in the past, and that allows us to create a treatment strategy that addresses much more than we can what most other practices are able to perform with the standard insurance model.
Yeah, and you factor in so much metabolic health optimization into their care here,
Right.
and movement and rehabilitation in that way.
Right.
So.